Hello, everyone. Welcome to day 3 of the Research Respite Summit. We're so glad to have all of you joining us today. My name is Kim Whitmore, and I have the honor of helping to facilitate the Respite Research Summit today, and want to welcome you on behalf of the Arch National Respite Center and thank them for hosting this amazing summit that we've had over the past few days. We are looking forward to day 3 being just as engaging and insightful as day 1 and 2 were. We want to remind you that the materials for the summit, including the agendas, the speaker bios, all the PowerPoints, and additional background about the summit and the Respite Research Initiative of ARCH can be found on the ARCH website on the summit page. You will see some links posted in the chat to help navigate to those web pages. We encourage you to keep your chat open throughout the day as we'll continue to post important links, and we encourage you to post questions and comments that you have throughout the presentations today as well. So if we could go to the next slide. My colleague Marcia is helping us to advance slides and also is posting links. So if you do have any technical issues, you can reach out to her and private message her throughout the day as well. But I want to just take a moment to highlight the Arch National Respite Network and Resource Center for those who may not be familiar. The Arch National Respite Network and Resource Center provides a wide variety of supports and services that are funded through the Administration for Community Living. So acknowledging that funding source that has continued to support the work of ARCH. One of the programs and services that is offered through ARCH is the Training and Technical Assistance Division that provides supports to the state respite coalition, service providers, and families through consultation, training, evaluation, and research. They also operate the National Respite Locator Service, which helps family caregivers and professionals locate respite services in their communities. And the National Respite Coalition is a policy and advocacy division of ARCH as well. So encourage you to take a look at ARCH's website if you're not familiar with any of these important services that are offered across the US. Next slide, please. Want to take a moment to acknowledge the amazing group of people that have helped to support the planning for this summit. I, again, am happy to be a part of this work and thank Jill Kagan for trusting in me to help facilitate this important summit for advancing respite research. Kagan, of course, is the director of the Arch National Respite Network and Resource Center. And we have Susan Janko-Summers and Cassandra Furman, who are longtime ARCH consultants who have put a lot of time and effort into supporting this summit. We also have Marcia O'Malley, who I mentioned previously, who is helping us with the tech support for today's summit as well. Next slide, please. We also want to take a moment to acknowledge the Committee for Advancement of Respite Research, what we like to call the CAR. So if you hear that throughout the day, the CAR is the Committee for Advancement of Respite Research. You can see the names and affiliations of all the members of the CAR. Throughout this summit, we have heard from several of the CAR members, and today we'll hear from a few additional CAR members. We'll hear from Ronnie Snyder, Ken Genowick, and Lauren Parker on some of the initiatives that they are working on as well. So thank you so much to all my colleagues who are here representing the CAR and for all the work that you have done over the past few years in helping to advance respite research through the work of the CAR. Next slide, please. So this is day 3. I want to take just a moment to recap all the amazing things that happened yesterday in day 2. If you did not get a chance to participate in day 2 and you want to review, those videos are going to be posted on the ARCH website in a few weeks. So we encourage you to watch back the recordings of those presentations. But here's just a quick recap of what we talked about yesterday. So first, we heard from some amazing programs across the country that are all designated as innovative and exemplary respite services through ARCH's program. And they were involved in an evaluation project. So these grantees worked with Susan Summers and Cassandra Furman and were able to enhance their evaluation efforts for their respite programs in order to become what we like to call research ready. And these groups did an incredible job yesterday of sharing the work that they've done, highlighting their evaluations. And if you didn't get a chance to check out the amazing data briefs that came out of their work, I think those are just exemplary. They highlight what their programs are about, the evaluation strategies they use, and some of the outcomes that they found in their evaluation plans. We heard from the Center for Volunteer Caregiving that serves older adults. They're measuring satisfaction and caregiver burden. We heard from the Claude Moore Precious Time program that provides students who support respite for children and youth with special healthcare needs. And some unique things they're measuring is caregiver self-efficacy, as well as the student outcomes from their participation in providing respite. And then we also heard from Vanessa Behan, who does emergency crisis respite. And what I loved about their evaluation is that they included caregiver self-defined wellness as an outcome evaluation measure. So really exciting to see the great evaluation work that is happening through our incredible programs across the country. And then the second half of the summit, we heard from emerging national, state, and local respite services evaluations that are a little more larger scale versus the individual programs that we heard from our grantees. We heard from the we heard about the Center for Dementia Respite Innovation, which has an incredible investment in supporting dementia respite across our country. They're using the RE-AIM evaluation framework and measuring both caregiver and staff outcomes. We heard from the Massachusetts Respite Innovation Grant Program, again, a huge investment to a lot of different grantees in the state of Massachusetts, and they're allowing programs to customize the metrics that they are evaluating for their programs using measures from both the process and outcome measures that align with the value of respite model that we talked about in day one. And finally, we heard more about the XL program. This is a program that is funded 27 respite projects in New York and Michigan, and they're looking at satisfaction as well as a variety of caregiver outcomes. And again, it was so inspiring to hear about all these amazing investments in respite and the robust evaluation plans that are helping us to understand the effectiveness and the outcomes and the value of respite for these services and programs. Next slide, please. We also ended with some robust discussion and question and answers. And some of the themes that I feel came up throughout the day that I wanted to highlight is, looking across all of the evaluation models that we saw, there was such a consistent alignment with the value of respite model. It was really nice to see that we're all starting to think about evaluating respite in similar ways. We still have this opportunity to continue to use common data elements across these evaluation projects. So we want to continue to promote and share the work of the CAR and the recommended common data elements as recommendations for evaluation and research moving forward. So we have better comparability across evaluation and research projects. We again talked about this concept of minimum effective dose of respite and thinking about, is the frequency and consistency that is needed to really have positive outcomes and show that value of respite. And we talked a lot again about the need for person and family-centered and tailored approaches with our respite work, as well as our evaluation. We brought up the concept of redefining respite a little bit yesterday and how really respite needs to be defined by the caregiver, that it is really important that respite is what the caregiver needs it to be. And that's an important factor that I think we can all continue to support, is thinking about those goal settings, understanding what is most meaningful for caregivers. We also talked a little bit about how important it is to also capture qualitative data through interviews and focus groups, help understand the broader context on the outcomes of respite as well. And also many of these programs had robust evaluation data around the respite model, and want to highlight again the new tool that was developed by the CAR to help describe the respite model that we again encourage folks to use moving forward. One of the things that I think stood out to me was this really neat opportunity we have to continue to try to develop new measures and measurement tools that help us more accurately measure respite experience and outcomes, and that these measures really should be informed by the caregivers. And we're going to hear more about that today and how we can truly engage with the community and ensure that we are understanding and building relationships to base our work on the needs of our caregivers and communities that we serve. And overall, there is this great need for continued growth in our evaluation and research methods to ensure that we have culturally and linguistically competent services and methods that we're using, which is a great segue to our topic for today. So again, overall, day 2 I thought was inspiring and wonderful and so enlightening. I learned so much and am so optimistic about the future of our evaluation efforts for respite programs across the country. You could go to the next slide, Marcia. Now I'd like to hear from you. For those of you who were in attendance at day 2 yesterday, would love for you just to drop in the chat one word that describes how you're feeling after day 2 of the summit. So feel free to just, drop that in the chat so we can hear from a few of you on how you're feeling, what day 2 was for you. We'll wait a minute just to see if we can get a few responses from folks. Inspired, knowledgeable, well-informed. Inspired, love it, hopeful. Thank you so much. Energized, exciting, exciting. And I feel the same way. I think we were really enriched by learning about the evaluation work at both the program level and some of these national initiatives and statewide initiatives that are really helping to advance our ability to capture data and understand the value of respite. So thank you so much. Feel free to continue to post your thoughts in the chat, but we're going to move on to the next slide. So here we are in day 3. As excited as I am to have day 3, it's also a little sad because this is our last day of the summit. And I know I left each day feeling hungry for more conversations and discussions. And so hopefully the end of this summit does not mean the end of these conversations, and we'll continue to engage and connect and collaborate moving forward. But we do have to bring the summit to a close today, and what a better way to do that than talking about the importance of cultural and linguistic competence in respite research and evaluation. So what we are going to do today is hear a little bit about how we can focus on diversity, equity, inclusion, and accessibility in respite research. If you go to the next slide, you'll see after that, we're going to be hearing from some of our funders, looking at philanthropy's role in advancing a respite research agenda that addresses the diverse needs of family caregivers. So we're going to hear from 2 foundations that help to fund some of this respite work. We're going to take a well-earned self-care break and then finish up the summit by hearing from 3 different presenters in a panel to discuss culturally and linguistically competent respite research. So we're going to hear more about a project led by Lauren Parker. I'm going to share about a research project that I was involved in with families of children with special health care needs from the Latinx community. And then we're also going to hear more about community engaged research from Khadijah Marquette Davis. So really excited to hear from all of those individuals. We'll have time for a Q&A at the end, and then we'll wrap up and talk about next steps. Next slide, please. As a reminder, this slide shows the overall summit objectives. Our hope across these 3 days is that we have helped to establish the foundational work of the CAR in advancing respite research. We want to make sure that we've highlighted current national, state, and local research evaluation and data collection initiatives that align with the work of the CAR. We also want to prioritize cultural and linguistic competence in respite research and demonstrate alignment of ARCH's CAR work with the national strategy to support family caregivers. And finally, and I think most importantly, we hope that the summit is a loud call to action to each of you who are participating, whether that's live or listening to these recordings later, so that we can all continue to work together to advance respite research. Next slide, please. Without further ado, you're going to hear from your first presenter, which is me. So I'm facilitating and introducing myself, which feels a little awkward, but here we go. I'm Kim Whitmore, and in addition to being the facilitator of the summit and a proud consultant with ARCH, I, by day, am an assistant professor in the College of Nursing at Marquette University, where I lead a program of research that looks to support the well-being of family caregivers and do a lot of work around respite research. I want to talk to you today about how we can focus our work with a diversity, equity, inclusion, and accessibility lens. So if we go to the next slide, Marcia, I have a question for all of you to start. So I'm wondering if you could just pop in the chat, how often does your work involve an intentional focus on equity, diversity, inclusion, and or accessibility? So you can respond with always, sometimes, not enough, um, always, daily, love it, um, always, always, this is great. Wonderful. So I think that's really important that we continue to keep that lens. I see a not enough and agree. I think as much as we may all be trying to do this, we can always do it better. We are here as learners trying to grow into this work as we move forward. So my hope is that the next couple slides that I share with you and discussion that we have subsequently will help us sort of reaffirm the things that we're doing well, but also challenge us to think of other ways that we can continue to strengthen our focus so that we can strive to improve our ability to engage in this work. Next slide, please. This slide has what I call the Kim Whitmore layperson definitions of some of these terms. There are, of course, many very robust, detailed, formal definitions, but I like to think of these terms in this way. I like to think of diversity as different perspectives, accessibility as ease of use, equity as fairness, and inclusion as feeling welcome. And to me, I feel that inclusion is sort of the epitome of it all. If we do everything else right, people are going to feel welcome, they're going to feel supported and a part of something in the work that we do. So to me, the end goal is always this sense of broad inclusion in our work. And all of these, of course, are interrelated, but we can't just have diversity, we can't just have accessibility, we need to strive for that equity and inclusion as well. If you go to the next slide, I just want to highlight that when we talk about diversity, we're talking about a lot of different things. I think traditionally and most commonly people think of racial and ethnic diversity, which are really important social identities that we need to focus on in our work. However, there are also other aspects and other social identities that are important to consider. And this is going to be very contextual to the individual families you work with, the communities that you serve, and your priorities and target populations that you're working with across the different programs that you're involved in or the research interests that you have. And so really want you to think broadly about diversity as well, thinking about how all of these social identities intersect as well. And I've added one to this since I last presented on this topic at the last summit, because I do think it's a really important identity that we often overlook. And that's the identity as a caregiver, and one that I think is most important to us as researchers working with respite and caregiving supports, is that identification as a caregiver is something that we need to make sure that we're highlighting as a social identity, in addition to the others that are listed on this slide. Next slide, please. This is an image that was developed by the Robert Wood Johnson Foundation that I think does a really excellent job of helping to illustrate the difference between equality, which is equal, and equity, which is fairness. So it represents at the individual level how we need to make sure that we are giving individuals what they need to be healthy. We can't give everyone the same. If we give everyone the same, not everyone is going to be able to achieve their health outcomes because it's not tailored for their unique needs, as is depicted from the top image. So these images, everyone has the same bike, but not everyone is the same. And so not everyone can use that bike in the same way. The analogy to that in the bottom image shows that in order for everyone to have their shot at being healthy and living their best lives, is we need to give people what meets their needs. We need to accommodate and adapt and tailor what we do to support their health. And so I love this image. I think it's a really nice visual way to differentiate between equality or equalness and equity or fairness as we move forward in our work. Next slide, please. From a respite standpoint, I have preached a lot about the 5 rights of respite care. I am a nurse by training, and so in nursing, we talk about the 5 rights of medication administration, and we want to make sure we give the right person the right medication at the right time and the right dose and the right route in order to make sure that they're getting what they need. I think we can think of that same analogy to respite. We want to make sure we're giving the right family the right type of respite at the right time, in the right duration, in the right location. These are all those pieces that are really important to match the family's unique needs in order for the respite care to be effective and result in positive outcomes. If you go to the next slide, you will see that this aligns really nicely with the value of respite model. So at the middle, in the value of respite model that we presented on in day 1 of the summit, you'll see an important piece of the respite process is making sure that there's acceptance of respite and that there's access to respite services that meet the needs of the family. And we have to recognize that those family needs are different for everyone. And they're situated in this context that we have caregivers who are interconnected with the care receivers that they support, and they're situated in the context of their family, community, policies, and systems, all of which vary and change over time and across the lifespan. So, this idea of tailoring our services is really important from a respite provider standpoint and aligns nicely with this value of respite model framework as well. And a huge aspect of that, which can impact acceptance and satisfaction with respite, is one's social identity, one's culture, one's language, all of those social constructs that we highlighted a few slides before. Next slide, please. This is another model that I developed earlier in my research career that I think just again gives a nice visual of how we need to make sure we're fitting all of these factors of respite to the family's unique needs, and that if they fit, if all those things match what the family needs, it can lead to positive health outcomes. If they don't fit, I've seen and I've heard that if it doesn't fit, it actually can lead to decreased outcomes. It can cause people to be more stressed. After a respite experience. So it's really important that we get it right for families. I've heard parents tell me in focus groups that they've, quote, failed respite before, which is just a sad thing to think about, that families feel like they tried respite and it didn't work for them, and they were failures of that because it didn't give them the break that they needed. And so we have an obligation to ensure that we are matching those services to their unique needs, and also in an evaluation and research framework, ensuring that we're asking about that match to ensure that we're measuring those outcomes fairly, because the hypothesis is that if they don't match, we may have decreased outcomes. So that match to their needs is very, very important. Next slide, please. So this is another image that I love that was developed by Matt Kingslow. His name is written on one of the buildings there. It's hard to read, but just a really nice visual depiction, again, of the difference between equality and equity, but at the community level. Again, recognizing that at the community level, we have to think about different populations, different geographic locations, different sectors of our community needing different resources and supports. So a certain community or a certain population may need a different type of respite, may need a different amount of investment in that to help promote equity and outcomes for those caregivers. Next slide, please. So here's the $1 million question. So how do we do it? How do we do equity, diversity, inclusion, and accessibility in respite research and evaluation as well? So next slide, I give some suggestions for this. So I really feel that this happens when research studies do the following. So as I read these, I want you to think about your work and if you do these things. So kind of make a mental checklist. Research studies that intentionally address disparities or inequities. Research studies that focus on historically underrepresented populations. Research studies that capture cultural context of participants. Again, that aligns with the value of respite model. Like, are we capturing that context in our demographic information? Research studies that engage community partners in the research process, especially family caregivers and individuals that they're caring for. We also love research that has established community advisory boards that are helping to partner and provide support and advice throughout the process. Research studies also should validate their findings back with the community. We often call that member checking in research terms, but making sure that what we think we found in our research and the conclusions we're drawing actually are what the community agrees with, that we're not misinterpreting what we heard and learned from the research and data that we looked at. And then finally, making sure that research results are disseminated in a way that is useful to the communities, that there's plain language summaries of these findings that are given back to community members. This could look like fact sheets or often policy briefs, things that can be used by the community for their own advocacy and knowledge sharing as well. So if you go to the next slide, I have some reflection questions for us to consider and talk about during our time today. So these are, again, questions to think about with your own work and challenge yourself to do if you're not already. So the first is your research team diverse, representative, and inclusive? So who's on your team? Do you have anyone who has experience as a caregiver or as a person with a disability who is helping to drive this work that you're doing? Are you cultivating authentic, meaningful, consistent relationships with diverse stakeholders, including those family caregivers, care receivers, and the respite providers? We want to make sure that community engaged work is done in a way that is thoughtful and has mutual benefit to those that we're working with as well. And then, are you engaging stakeholders at all stages of the research process? Again, this includes when you're forming your research questions. Are you listening to what people think is something that should be addressed in your research? Or are you just coming in with what you feel is the problem or the issue? Are you truly listening to the needs of that community that you're engaging with? Are they helping to inform the study design and methods, making sure that what you're trying to do is not overwhelming or difficult, making sure it's feasible and will be acceptable to the community? Are they helping to review recruitment materials to make sure they're meaningful and, again, will speak to the people you're trying to recruit? Are they helping with the data collection? Are they involved in the analysis at all? Are they, again, assisting with that dissemination and the messaging that you're using to share your results? The next reflection question is, are all the study materials accessible and linguistically appropriate given the audiences that you're trying to reach, the people you're trying to engage in your study? Or are you limiting and excluding groups because of this? How can we continue to advance and expand our reach to these populations that are often underrepresented because of these barriers? The next question, what implicit biases do you or your team need to unlearn to avoid biased data collection and biased dissemination? Often what we collect, how we collect it, and how we share results can reinforce bias and stereotypes that exist. And we need to be really careful that our lens on this work is such that it filters that out and helps to create and helps to avoid undue bias in the work that we do. And then finally, what inequities need to be prioritized in your work? So thinking of the area that you're most interested in, where are there inequities that could be a priority in the work that you do? So as we think about all of these questions, I'd like to take a few minutes to engage with you all and have some dialogue. We have about 15 minutes talk about this, to talk about the work that you're doing. So I'd ask Marcia to share the screen so we can all see each other, and welcome some discussion with all of you to talk about what you're doing, what you feel you could be doing better, any questions that you have about the content that I shared. So you can feel free to post in the chat or unmute, raise your hand, and we'll call on you. So Doris, I see you waving.
Yes, this is personal to me. So I was counting down to this day.
Great.
I think this respite conversation, when it comes to the community I work with, which is the Latino community, it's so hard because it doesn't translate. The context doesn't translate. So the word respite, which in Spanish translates to breathe, it doesn't resonate, and it's very hard to get the community to understand that this is available, that this exists, that we here in the United States value and recognize this. So maybe in their communities and their cultures, it's not, you're supposed to, not be stressed or whatever. But here, no. So getting them to acknowledge themselves as caregivers and understand that they may need respite, so hard. How can I help, or how can I find help in relaying this message to them, saying that this exists here? And we call it instead of respite, we call it relief, relevo familiar. It translates the context a little better, but it doesn't exist in these countries. So I keep trying to talk about this, and they're saying, I don't know what that is. Why do I have to breathe? So it's like, oh, forget it. So that's where we have our biggest mountain that we try to come across.
Absolutely. And my presentation later today is on research I've done with the Latino community. And my short answer to that is, you have to have the conversations with them. You have to help them see it, to understand it. Because I heard that from many families. I've never heard of respite. What is this? And then once I tell them what it is, they're like, oh my gosh, how do I get that? That's amazing, right? Sign me up. Can I get it tomorrow, right? And that's just one barrier in that community, right? Then it's, do we have cultural and linguistical services? Are there concerns about documentation status that are limiting their access to these things? There's so many other nuances in that community as well. In addition to just the terminology and the cultural acceptance of that, right? And so it is a hard barrier to come, but it starts, I think, with those genuine, authentic conversations with people, getting to their level, building that trust, helping them to know what it is we're actually talking about. And I think it's part of what has biased a lot of the research that we've seen, that there's been some studies that have shown that there isn't as great a need for respite in communities that are from Spanish-speaking countries, especially. And it's because if they saw a question that says, do you need respite? They're going to say no, because they don't know what it is.
I know.
Right?
They don't use hospice either, because the word has a different meaning. So it's very hard to kind of, it's hard to believe that someone is worried about your stress levels, and someone is worried about your tolerance for long-term care of these family members that you are in charging yourself with. So therefore respite will save you. I'm trying to get that, and I'm thinking with their thick skulls, and I'm just like, please let us help you. And they're like, no, we're fine, really. Like, oh.
Yes.
Yeah.
And it can be too that, I see a comment in the chat from Adam who says, it's so hard where I'm located. We have Hispanics and tribal communities. It's hard for these communities to accept help or respite or relief, as Dora states, from someone that is not within those communities. And that's a huge issue, right? Like making sure we have culturally competent, congruent support and services that are from the community. And Darlene added that in New Hampshire, they don't have a respite coalition. How can I move forward to get this state started? Oh, that's a bigger question. So we can talk offline and connect with Arch more about that. So maybe shoot an email about getting connected on that. And then Kay says, isn't America one of the only places that calls it respite instead of short breaks? Yes, it is. So again, the term respite is something that we call it that. We have to label it, define it, so we know what we're talking about. But when we're recruiting in our studies, when we're talking to people about it, even when you're promoting your programs, right? We may not want to call it respite. It's, do you need a break? Would you like some time away? Do you need time for you? How can we support your mental health as a caregiver? Or, using more plain language to help people really understand what it is we're trying to talk about, because that term is not as accessible to as many people as we think it is. Same with the term caregiver, right? So there's been some great campaign work that has been done, and in different places where instead of calling it respite, they say, or calling it caregivers, they say, do you do this? We call that caregiving. You need a break, we call that respite, right? So we have to help people understand what we're talking about, which is really important. I see Georgia has their hand up.
Hi, Kim.
Hello.
Hi. So, I'm Georgia. I'm here in Omaha, Nebraska, and I support the Nebraska Lifespan Respite Network. And if you're not from Omaha, you probably assume we're not very diverse, but we are an extremely diverse city. Nebraska has 3 times the number of refugees than any other state in the US. Um, and when I was pulling data from our surveys, the only data I was seeing is the picture of the caregiver was a white woman in her 40s to 50s, but I know that's not the face of caregiving here in Omaha because we definitely have more than just Caucasian women. But it was because it wasn't being distributed to anybody else. It wasn't available in any other languages. It was only available in English. It was only going to those who had a smartphone. It was only being distributed to those through their employer who maybe had a wellness department. And that's not the case for everybody. So we really spent the time last year to procure extra funding, and we translated all of our infrastructure into 13 different languages. And I don't just mean the brochure. It's the brochure, the application, the billing document, the website, the provider orientation. Everything is now in 13 different languages. But then it's like, how do I get this out there? So what I did was I connected with our unique neighborhoods kind of leadership, so to speak. I joined what we have an Omaha Refugee Task Force. That was started years ago, but there's certain individuals in each refugee community that are pillars of their community that speak on behalf of individuals from their country who are deeply trusted by new arrivals. Oftentimes, the pillars of the community have been resettled for about a decade or so. So I connected with them. If I can earn the trust and get to know the leaders of the communities, then that kind of opened up the doors for me to come and speak to their loved ones, and then their loved ones, and their loved ones. And you have to approach it from a different angle because we are so centric in the way we think about distributing information. Not everybody has an email. Not everybody has a smartphone. Not everybody has a social security number.
Yep.
So I knew that I'd connected with the Somali community. They had a community center all their own. So I made the trip up north to meet with them in person because they like in person. They don't like Zoom. They don't like telephone. They want to see you. And I had all of the materials in Somali. And I remember when I handed the application to this one woman, she wanted to be a provider. Just the look on her face was like, oh my God, this is in Somali. She was so blown away. And
Yeah.
it takes more effort, but you've got to connect with those in their communities that they know and trust, that are their community leaders.
Absolutely. Absolutely. And I would add to that, we need to also be very mindful that we are compensating those that we are connecting with and asking to support us in some way as well. Because many of those, pillars in the community that are often, the spokespersons, the leaders, they get tapped a lot for different things. And it's really important that it's a mutually beneficial relationship, that we are either compensating their time or helping to support them in a way that makes them feel there's equity in that relationship, that we're not just constantly asking them to help us do things, that we're hiring them, we're paying them stipends, we're bringing food, we're showing up, we're supporting their work. Even as simple as like the group that I'm going to talk more about later today, like I showed up at their Christmas parties and donated Christmas presents, just try to do whatever I can to support the community, to know that they, help them know that I really do care, that I'm not just here to pop in and pop out. That authentic long-term commitment to those relationships is really important in your work.
Yeah, we're planning a dinner with the Afghan community at a restaurant that is owned by an Afghan refugee. And it's like that community's favorite place to go eat. I've never had Afghan food before. But but it's just for them to take a break
Yep.
and go out. But it's, yeah, again, that very symbiotic, because you don't want to feel like you're taking.
Yep. Yeah, great conversation. I see another comment. Oh, a couple comments in the chat, more about tribal communities, great ideas, great thoughts. Um, Many of the caregivers are in denial or convince themselves that they didn't need a break. Oh, I love this comment in here. Yeah, like I think people don't know what they're missing, right? um, Wonderful. See a hand up from Catherine. Catherine, you have a comment or question?
I do. I have a comment. So I'm Catherine Carroll. I'm with the Association on Aging in New York. It was really nice to see Doris. Hi, that you're on here. So many great projects in New York, and I just wanted to offer my thanks for your presentation, and also a comment, which is that my focus is on disability and aging, and I wanted to highlight this I guess idea, or like something I've come up against, which is talking with pilot projects researchers who don't necessarily feel like their process or their methodologies need to be accessible to people with disabilities because they're not, quote, studying people with disabilities.
Mm,
And I think that's problematic for a number of reasons. One, whatever group you are studying cross cuts with disability.
yeah.
And then whatever process or methodology you're using, you're kind of embedding, if it's not accessible, you're basically embedding it further. And when you roll out, when you go bigger, it's going to be harder to make changes to that process or methodology to make it more accessible when you want it to be available to all people. So I just wanted to highlight that. And if anyone has done the work on the accessibility side where you weren't, quote unquote, studying people with disabilities, I would love to hear about it. And I just, again, thank you for the presentation.
Yeah, I appreciate that comment because I think it remains true that individuals with disabilities are the largest minority population in our country, right? And they cross and intersect with all the other social identity constructs that we mentioned. And we need to start approaching things with sort of that universal design, right? That we are creating things in a way that are accessible, useful to all. I don't think we've done a great job of that. That's definitely something that we need to put some more work into. And maybe that's an initiative we work on collaboratively together to figure out how do we do that better. Because I do think that's a major barrier. I think we're getting better at putting things in different languages, but not necessarily creating documents in a way that are readable by people who need technology to help them read, right? That are, designing things that allow people, like if we're doing in-person recruitment and strategies, making sure that there's even just a physical environmental accessibility for people to engage in our programs and our research that we do as well. So much work to be done on that. I could talk for about 4 more hours with all of you about this, but unfortunately we do got to move on in our summit. Again, welcome the continued conversations. We're going to have more conversations today about this as well. So please continue to post questions or thoughts you have in the chat so we don't lose those great ideas and questions, and we'll try to answer those as we can.